Welcome to the new sound of online radio. Welcome to the sound of Universal Broadcasting Network. 'Cause you make me feel like I've been locked out of heaven. A mix of today's hits and hard-to-find favorites, combined with the most entertaining and intriguing talk anywhere. This is your sound. This is the sound of Universal Broadcasting Network at UBNradio.com.
You're listening to The Dr. D Show about neuropsychology and well-being. Get the knowledge you must have to live a powerful, positive life. The Dr. D Show. Here for you.
Welcome, listeners, to the Dr. D Show today. I'm very happy you are with us. As usual, the typical disclaimers. This show is psychoeducational in essence. It is not meant to replace professional mental health advice or therapy. If you do believe that you suffer from a particular disorder or medical condition, please do reach out to professional help. With that in mind, some of the topics that we cover are not appropriate for the younger population. Hence, your discretion is advised. I am excited to have with us today Dr. Jerome Lisk. He is a neurologist with extensive experience in the area of movement disorders. We will go ahead and attempt to cover as much as possible today some of the typical questions that come my way and the way of many of us professionals who deal with neurological conditions with the assistance of Dr. Lisk today. I'm going to go ahead and go over briefly the... And it is a challenge, Dr. Lisk's bio, since he has very many pages of both educational and work experience in the field. Dr. Lisk is a board-certified neurologist, has been and currently involved in several national clinical trials in Parkinson's disease. Dr. Lisk earned his medical degree at the Medical College of Virginia, internal medicine internship at UCLA, neurology residency and movement disorders fellowship at the University of Texas at Houston, also involved at the Movement Disorder Society, the Solo Small Practice Committee of the American Academy of Neurology, and Medical Advisory Board of the California State Athletic Commission. Dr. Lisk has been on the board of directors for the American Heart Association, Western States, Alzheimer's Association board member, Southwest Missouri chapter, as well as appearing on several local news, radio, satellite radio stations. And furthermore, Dr. Lisk is a 2013 graduate of the American Academy of Neurology Palliative Advocacy Leadership Forum, an expert reviewer for the Medical Board of California, and voted as one of Pasadena's top doctors by Pasadena Magazine. Dr. Lisk, welcome to the show.
Thank you. It's glad to be back.
It's wonderful to have you on again. And the topic of movement disorders is always once in a while come back to, from my listeners, come back as multiple questions that do show there's always some sense of confusion. So let's perhaps start at the beginning. What are movement disorders?
Well, movement disorders is kind of what the name implies. Whenever there's abnormal movement of the body, this differs from like when you have neuromuscular disorders where you have muscle twitching that's due to atrophy. Movement disorders are more like dystonia, which is a muscle contraction that has an abnormal posture, that holds an abnormal posture, kind of like a Charlie horse, I try to tell patients. Tremors, like Parkinson's disease, essential tremor, Huntington's chorea, where there's excess movement. So mainly it's usually when there's excess movement or a lack of movement or decreased movement.
And most individuals are familiar with Parkinson's disease, but there are other movement disorders. Is that correct, that individuals are not familiar with?
Yes, there are. And one that they are familiar with is essential tremor, and that happens to be the most common movement disorder in the world. Way above Parkinson's disease. But since it doesn't lead to any real bad outcomes, it doesn't get as much recognition. Also, dystonia is a rare but common movement disorder, and people suffer from generalized dystonia that they're born with. Sometimes you see these people walking, or they're in a pretzel-like situation where they're sitting. And then there's also cervical dystonia, where the neck can be twisted in a certain position and cause pain. And the other name for that is spasmodic torticollis, and we give botulinum toxin for that. Then there's Huntington's chorea.
And one question that came my way was an individual who has her parent having some level of tremors, but she believes that is her father, and she believes that it could be caused by alcohol, but her father is very resistant of seeing a neurologist, and she's not sure if this is an age-related problem, is that a movement disorder, is that alcohol? What would be the course of action someone would take in such a situation?
Yeah, that's the differential diagnosis there includes all of that. That situation, you can have tremors from chronic alcohol use over years, because that could cause degeneration in a certain part of the brain that's in the back. If you reach back in your head and you feel a little knot in your head, and you reach right below that, there's an area there called the cerebellum that helps us with our coordination. The top part of that could be affected in alcoholism. Secondly, he can be developing either essential tremor or Parkinson's disease. So looking for a gait abnormality, are there any memory problems? He may also have cognitive problems from alcohol use. And so these are the kind of things that you want to look for. So really an MRI of the brain is very useful in ruling out causes. I have seen the American Academy of Neurology has pictures in the Green Journal, which is our neurology journal that goes out to all neurologists. I've seen an aneurysm and a brain tumor cause symptoms of Parkinsonism that the patient did not have Parkinson's disease. So an MRI helps rule out other causes that are rare or atypical.
And would not be the case that as people age, the brain goes through multiple things? So in reality, we don't always get a brain with a perfect picture of, let's say, Parkinson or another disorder. But there's also the imaging may show history of other conditions like infarcts and past strokes or etc. So wouldn't that then complicate the picture or the diagnosis?
Yes, it would, because as we age, there is something called physiological tremor, and that's a tremor of natural aging. But that looks more like essential tremor, and that usually occurs with people when they're in their 90s. If you do have strokes or you have high blood pressure that causes damage over time, and let's say you just have high blood pressure that causes damage to the brain over time, just little tiny losses of blood we call ischemic damage in the brain that causes little white spots that accumulate and then coalesce. Those can cause difficulty with thinking, memory, and cause something called vascular Parkinsonism. So yes, it can complicate the picture. That's why frequently when you go, he would go to an office, neurologist, they would take a detailed history, and the questions would help rule out certain things, help narrow down the lists of all the things it could be, do an MRI of the brain to rule out that there's nothing. You cannot see Parkinson's disease on MRI of the brain. That's a lot of people think that. We're not doing that to see Parkinson's disease. We're doing that to rule out other things that may be a chameleon, may look like it. Mm-hmm. And then that really helps narrow things down, as well as sometimes we do some blood work.
And that's pretty much what we see in neuropsychology. We often will get cases where it's a suspected case of Parkinson because the imaging was not something that was indicating that, just as you were saying. Some of what we see in neuropsych, and I perhaps would like you to comment on, are some of the emotional changes that individuals who have Parkinson go through, what they normally would show on a psychological level. Beyond just a movement situation.
Yeah, so of course, with neuropsych, you're the expert in that, but what we see clinically is we will see, sometimes we see, of course, depression, we see minor depression. Minor depression is more common than major depression in Parkinson's disease. They have apathy, and the depression with major depression in Parkinson's disease does kind of differ. I think they have a more of a loss of interest. Well, I say loss of pleasure than a lack of interest. Unless they have apathy, then of course they may have a lack of interest as well. Pseudobulbar affect disorder. That's another disorder where people may cry or laugh inappropriately. And we're noticing now, there was an article in the JAMA Neurology stating that patients with Alzheimer's disease that have behavioral problems where they may get agitated or irritated easily may also have this pseudobulbar affect. So it's not just laughing inappropriately or crying inappropriately. It may be any type of inappropriate emotion that they cannot suppress.
And as dementia kicks in addition, then there would be that loss of control of inhibition of emotions, making maybe inappropriate comments, etc. And that would be some of the signs we would see in terms of neuropsych, that when the family maybe reports that the person gave a speech and they're often a very respected individual and they say something awkward in that speech or anything else. That's very interesting because some of the questions that come our way are also confusion that family members have about how to communicate with their loved ones once they are diagnosed. What would be maybe some guidelines that you can give those families?
Yeah, that's a very good question. Also, previous to that, like you're right, impulse control is definitely a problem as well. I try to tell, because almost everyone with Parkinson's eventually develops cognitive impairment, because when you have a neurodegenerative disorder, you're going to have brain atrophy, and it's almost like advanced aging because the brain is degenerating faster than it normally would when you age. And so there's going to be the thinking and processing information in the frontal lobes is going to be affected. And when you have memory and the ability to think, process information, reason, your insight, your judgment is affected. Many times you have a couple that maybe have been married 30 years or 20 years, and the spouse will treat the partner as if they didn't have a disease at all when they're dealing with things, and they'll argue with them. So what I say is, don't become confrontational. Try to redirect people. If that doesn't work, sometimes, distracting them to something else may work as well. But they have to constantly remind themselves that they are not talking to the same person that did not have this disease 10 years ago. They're now talking to someone that has that may be argumentative and defensive with them, but it's because of the disease and not them.
It's an excellent point. It's an excellent point you're saying, because it becomes personal. As you said, when people are together for many, many years, whether it's their spouse or the children, people make the mistake sometimes of thinking that the comments that are made on a personal or interpersonal level, maybe to get back at them, or it's kind of like a marital discord. And it is important to separate in order to reduce the frustration level, especially if there's dementia and the person continuously repeats the same issue despite, so that's an excellent point.
They need to take a break too. They need to be able to, caregiver burnout. They need to be able to take time out for themselves. They need a support system as well to have people kind of help them, and seek other caregiver services like the Caregiver Family Alliance, I believe. There's different organizations for caregivers to help them with services and advice.
And that's important because also I think one of the difficult part in the job of giving a diagnosis of a progressive condition that's not curable at this point in time is that we're giving a doom and gloom. And part of the difficulty is that the next question often that's inevitable is, what's the good news here? What can I do about it?
Right. We often think about the patient and don't think about the caregiver. So that's one thing they're trying to really enforce in the doctors, is to also think of the family, and educating the family is key. The more you educate the family, the more they can deal with issues at home, and the more they know how to deal with issues.
What kind of treatments are out there that, I guess, and this question will be broken to a few parts, but what treatments are available out there currently that are essentially affordable and possible for people to have? And then the second question would be, what kind of new trials do we have now that we should look forward to seeing them developing, hopefully, into something more promising?
Okay, so we're talking about treatments and trials for Parkinson's disease, correct?
Correct.
Okay. So some of the new treatments that are out, some of these are, I'm going to say one that was just started last year, came out last year. There's a drug called Rytary. It's R-Y-T-A-R-Y. It's the first extended release carbidopa-levodopa on the market. There's another medication called Sinemet CR that people always tend to mistake for extended release, which it is not extended release. It's more like a coated aspirin. So Rytary is one. There's another medication called Duodopa. This Duodopa is an infusion pump that's they stick a tube they put a J tube in the stomach. And so it's almost like a feeding tube, but it's just a tube right there, and there's a pump that pumps the carbidopa-levodopa into the first part of the intestines. There's another medication that's in. Let's see, what else is out besides that? There's then we have the common medications, of course, Azilect, Nirapex, Sinemet. There's a medication called pimavanserin that's just been recently approved by the FDA. This medication is used to treat Parkinson's psychosis. This one is important because there's a black box warning with most antipsychotics causing death in dementia. The only one we could use now is Seroquel and Clozaril. This pimavanserin will have the best efficacy with the least number of side effects.
And
as far as clinical okay. What?
Yes, and for just for our listeners, what is Parkinson's psychosis, and why is it an important term?
So Parkinson's psychosis is where you have visual hallucinations. You could have something called false sense of presence. What that is that you see a shadow in your peripheral vision, and then you look and it's not there. And so sometimes people see little animals or, snakes or rats in the peripheral vision are shadow and it's not there. That's called false sense of presence. Also delusions as well is another. Now delusions happen about 10% of the time. Visual hallucinations, happen way more than auditory hallucinations. So auditory hallucinations, you're hearing things that are not there. That's extremely rare. So with clinical trials, there's a couple other medications. They're basically developing about 7 other extended release carbidopa-levodopas, and there's a couple of dopamine agonists that I'm involved with in clinical trials.
So those ones are dealing really a lot with the symptoms of Parkinson's. In terms of symptoms, motor symptoms of maybe other movement disorders, is that pretty much, are the medications about the same for the motor component, or are they different?
Oh, the medication, right now we don't have any medications for the motor component. There was I can't remember the name of it right now, but there was an herb that they were studying in China at China Baptist University, and it was to treat some of the motor symptoms. I saw it a couple of years ago, but I haven't seen any follow up on that. And right now we just don't have any. Now there's a cancer drug that actually has gotten a lot of buzz. as treating Parkinson's is being done at Georgetown University. It's only been done in phase 1, phase 2 trials, and it's been reported on NPR and other Michael J. Fox's website. And supposedly the claims is that this it's spelled Nilotinib, so natolabib. And some people think that this may actually help reverse some of the symptoms of Parkinson's disease by driving the abnormal protein out the spinal fluid and out the brain into the blood, where it's broken down and excreted in the urine or feces.
So it's in clinical trials at this point?
Yes, that's in clinical trials. It's not. If you look at the National Parkinson's Foundation website, it's not ready for prime time. Patients all across the United States are asking their doctors about it, but we need more trials and large trials to see if this could be reproduced in more than just one university.
Some cognitive disorders, as you say that, I think some of those cognitive disorders that are more progressive and many of the types of dementias affect the level of awareness of the patient as to the fact that they're suffering from something and how severe it is, or the way they look to other people. And in a way, it's sometimes a blessing because it's protective for them. With Parkinson's, we find that most of them are actually quite aware, and for many years they are aware of the way they are motor-wise within a social environment. And I think that that's an area that can cause just by itself, in addition to the neurochemical component, a level of depression or a level of frustration for those patients. And I think that if we can get any treatment for the motor component, it would make a big difference for a lot of individuals.
Yeah, if we could actually reverse it, we have medications for the motor symptoms, but those non-motor symptoms that's the real challenge, because the non-motor symptoms could be more disabling than the motor symptoms for a lot of patients.
What happens in terms of difficulties with eating, with internal processes actually? Maybe gastrointestinal processes.
Yeah, it's thought, there's been a lot of publications, literature of, they've done colon biopsies of the salivary glands, because there's this thought, kind of what Hippocrates said, is that all disease starts in the gut. They believe that Parkinson's may start in the gut. So maybe there's some environmental thing we're taking in, substance, chemical, and your genes is the gun and the environment is the trigger. And so there's a lot of research in that. We know the GI system is affected before you have your first physical signs of Parkinsonism. Your sense of smell and your GI tract and the autonomic nerves to the heart are affected. So everything is slowed down. And this one nerve that affects, all of that except for the sense of smell, that's called the vagus nerve.
Mm-hmm. Actually, UCLA has some treatments that I believe they're working on in terms of looking at cognitive impairment and the vagus nerve and autonomic response, and see if there's any perhaps therapies that could cater to that. So that'll be interesting to see. The sense of smell is sort of related to a lot of cognitive conditions, and particularly dementias. Which I don't think we have, relatively to other things, we haven't researched as well. There are some studies that have been done with the olfactory system, but I think there's a lot that can be done in that area.
Yes. They've actually seen where patients that there are certain Parkinsonisms that people don't know about called atypical Parkinsonisms, or we call them Parkinson's plus, or we call them secondary Parkinson's disorders. And one is called multiple system atrophy. Another one's called progressive supranuclear palsy. Mm-hmm. Another one's called cortical basilar degeneration. And there's a bunch of others. Lewy body dementia, like with Robin Williams, passed away as. And patients are sometimes mistakenly diagnosed with Parkinson's disease when they have Lewy body dementia. The sense of smell is usually normal in multiple system atrophy, but it's decreased in Parkinson's disease 70% of the time.
Very interesting. Now, what are other risk factors that we know increase the chance of someone developing a Parkinson?
also age is definitely a risk factor. They tried to link it to occupations such as welders, because welders, they're dealing with a lot of heavy metals. They've tried to link it to a few other occupations. Besides age, well water, because sometimes they'll have manganese in the well water. And
was that substantiated?
Yeah, there's a chemical. It's a long word. I can't remember the whole one, but there's one called TCE that it's used in dry cleaners companies, and sometimes the companies dump their chemicals places that they shouldn't, and that seeps into the water tables. And this has been shown to also poison the mitochondria in the cell, which is a little organelle that's in our cell that gives us energy. Organic solvents and pesticides do the same thing. And there's been plenty of studies proving this, and they all target this one little organelle in the cell called the mitochondria. All the poisons that cause Parkinson's disease.
Very interesting.
Like that book, Case of the Frozen Addicts.
Right, right.
Yeah. The MPTP chemical that the heroin addicts in San Francisco were these kids, 20s and 30s, were coming down with severe Parkinsonism overnight from the heroin.
Right. Now that you say it, I'm thinking about having the author on the show talking about this. His book.
Langston. Yeah, I know him. Yeah.
This is very interesting, and I think part of what it is with metals and chemicals in general is while we have some regulations on the way that those chemicals are handled and dumped, and they're not always being followed, and it's very difficult to monitor that. And LA had multiple, I should say Southern California, has had multiple cases where chemicals were dumped in unauthorized locations that actually affected the population. And in fact, it remains to be seen what is going on now in terms of the methane and the natural gas situation that we're having in Porter Ranch, because there are more and more cases that are coming up now as being linked to that. And I have one case specifically that is just a fascinating, non-typical but definite dementia. Of a woman who's lived there and was retired and stayed at the home majority of the day for about 3 years and being affected. And she was one of the first cases, actually, that was reported. Now, it has been settled with the company, but the treatment now, what kind of treatments can be given? Should people relocate? I understand from that case that the whole neighborhood left.
Yeah, they just brought up criminal charges on the gas company. I heard this morning on the radio.
Right.
There's, guess which state in the United States of America has the highest incidence of Parkinson's disease? And I'll give you a hint. It starts with an N.
Okay. Are we talking about Nevada?
Nebraska. Because of the agriculture, and all the chemicals they use, the pesticides and the pesticides they use. And so that's one. The Amish community has the largest, probably, incidence of Parkinson's disease as well. And so the countries, the United States is number one in incidence of Parkinson's disease. I think Japan is in the top 5. The 2 countries that have the lowest incidence of Parkinson's disease in the world is Ethiopia and Korea.
Wow. And China? Do you know about China?
I think they're in the top 10, definitely.
Also, yeah.
Because it's going to increase. It's going to more than double in some countries. It's going to double by, there's a chart, there's a graph we have in one of our PowerPoint slides from up to 2030. From 2015 to 2030, they predicted that it will double, and this is mainly in industrialized countries where they are using more chemicals and more food colorings in your food. I tell my patients, never eat a color and a number.
Right. Right. If it doesn't have a name of a color that you learned in first grade, don't eat it.
They should be putting turmeric not in there to color the food, not yellow number 5.
Right.
Can cause...
Or red 40.
Yeah, red 40, which is derived from petroleum.
Right. Right. And it's fascinating. I always tell patients also, don't eat anything that you don't understand what it says in the ingredients list.
Right,
If you can't
exactly.
pronounce this and you don't know what it is, for
Yeah,
likelihood you should be ingesting it.
or if you get tired of reading,
Right.
you shouldn't have to read forever. If you all of a sudden get tired of reading, there's too much in there.
You know, I used to do accounting for big food companies before I went to the PhD program. And part of what I learned from that is what kind of ingredients go into processed food and what companies are allowed to do, and what percent of the food can be what it is that they say it is. So a meatball can have only 30%, for example, of meat, and even that component of meat can have quite a variety of what type of meat it is, and it still can be called a meatball. So for the layman, that's pretty much, that is not being covered of what actually goes into that other 70%. So that's such an important point. Now, so we talked about location, maybe being near agriculture or metals, chemicals. But chemicals is like a difficult thing to escape. I mean, cancer is linked to chemicals. We talked about dementia. What do people do? How could they function without actually having some level of exposure to chemicals?
Well, then kind of just educating yourself, because I really didn't educate myself about, for example, water until until about 5 years ago. And there's these, I used to look at them selling the Brita filters and all this stuff, and I say, forget that. But there's actually, they have these, they have two different types of filters. One filters out a lot of organic things, like I've learned that, you have bacteria in the water. Sometimes you have little virus particles in there, or cyst may end up in your drink in the city water. So, buying a water filter that you hook up on your sink is key. Knowing the difference between the two water filters and what they filter out, and there's a government site for that. Other thing you could do is start really learning more about your food, and like you said, educating yourself about the food you eat and what's actually in the food you eat. So that's another thing.
That's a very important thing, and it is going towards health. And I think that sometimes, and that's part of what I'm trying to do in this show, always is make sure that the information that's coming in is also reasonable information. I think there's some harm being done when the industry goes into areas, the nutrition industry can go into areas that are not necessarily supported. But what we know scientifically, for example, with coconut oil and every natural product essentially has a benefit to it, but an absorption of anything is generally not a good idea.
Right. And we think as people that when we take something good that's natural, it's supposed to work right away. And I tell people that the only thing that works right away in nature, those things are called poisons.
Right.
Okay? So, good things take time to actually work. And, that's important to also realize.
Isn't that anything in life, though? Most good things take time. But it is true, though. The body does need to detoxify. That's essentially, I think, what you're saying is that the body needs time to get used to a new lifestyle, way of eating. I have a monthly class that's psychoeducational, all about nutrition and how to gradually change the way you're eating so your body can start recognizing new ways of eating, enjoying other tastes. Part of that is with sugar.
Right.
And I don't want to go too much into that topic, but sugar hijacks the brain where you don't get to enjoy other tastes. And
Yes. Imaging shows, they've done MRI spectroscopy showing that a functional MRI, not MRI, that's not spec, where they showed that the sugar actually lights up the same area of the brain as cocaine.
right, it's addicting.
Right.
Or it has the same level of addiction. And normally what I notice is when individuals gradually come off of sugar. And when we say sugar, it's the processed food as well because it's loaded with sugar. They suddenly start enjoying bitter and sour and all sorts of tastes and even a bit of salty. And they learn to enjoy that without having to feel like they always need to have something sweet. So that's interesting. Going back to our topic a bit more.
I'll tell you one more thing that I do.
Sure.
Is that I use Himalayan salt, not the regular salt.
Right.
And Dr. Keith Black at Cedars-Sinai had mentioned that he believes air pollution can actually cause lung cancer. And so when you're driving in your car, especially if you're on the highway, drive with your vents closed because all the cars in front of you in this little packed area are basically putting all the exhaust, all that waste out the car right through your vents, and you're just breathing that in on the highway.
That's, well, wow. For people in LA, that's such bad news. No escape. But so that's great. That's great advice right there. Now, one of the, so we talked about, issues of food. We talked about metals, age. Now, there's something, though, that early onset of any of those movement disorders or early onset of, and that's different. What is that?
So when you have young onset Parkinson's disease, 50% of young onset Parkinson's disease, which we mean Parkinson's disease before the age of 40, 50% is genetic. Okay, so a family history of there's only maybe about 10% of Parkinson's disease is genetic when you're over 65, when you're over 50, let's say. And family history does not mean you're at increased risk, okay? But when you have like Huntington's chorea, where they have those genetic repeats, every time that person has a child, those genetic repeats get longer, and every time those genetic repeats get longer, the disease becomes more severe.
And so it actually exacerbates itself or increases the chances with generations.
Yeah, so you just get it younger and younger and younger, and so that's why there's genetic counseling for Huntington's chorea.
What are some of the youngest ages you've seen?
Oh, you can see kids with Huntington's chorea.
Wow.
But what I've seen kids around 10 years old having little involuntary movements in their sleep. Had a mother come in she was concerned. She didn't know she was having involuntary facial movements. And she said her kids sometimes have these little involuntary movements in their sleep. And there's a few articles out there showing that before you develop Huntington's chorea, you can have these little involuntary movements in your sleep.
So it could be a sign of the disease coming.
Yes. Exactly.
We had on the show, I don't know if you know Matt Carey, who has early onset from a very young age of Parkinson's. He came and spoke for us, and a couple of other people. And one of the hallmark communications that they had is the difficulty carrying themselves throughout the day with the changes, both in mood and level of energy. So the top things were the fatigue and the mood. What can you say to that?
Well, that could be another complicated issue because sometimes the medications, like medications such as dopamine agonists, may make you sleepy. The older you are, the sleepier it makes you. The younger you are, usually you don't have those side effects, but you can. So there was an article in the Movement Disorder Journal, is it the medication or the disease? Parkinson's itself, before you even develop motor symptoms, you have something called REM sleep behavior disorder, where you're acting out your dreams in your sleep. So we know it affects sleep sometimes 10 to 20 years before you even have any physical symptoms. And almost 60 to 90% of people with Parkinson's disease have sleep apnea. So sleep apnea can make you fatigued. So a lot of these patients may need sleep studies, but they may not feel they need it because they're unconscious. And our idea of sleeping good is meaning that we're just knocked out. So I tell them, well, when the boxer gets knocked out in the ring, he's sleeping too. Okay, but he's not sleeping good.
Right.
So being unconscious doesn't mean you're sleeping good.
Right, right. That's a good way of explaining it. So, so
Yeah,
sleeping
I
is
always
an
get a
issue.
chuckle out of that one.
Well, I've also had, I'll say it on a side note, I do concussions mainly. And I always have to ask if somebody had a concussion in three different ways, because I'll say, especially for younger people, but I'll say something like, have you had a traumatic brain injury? Oh, no. Have you had a concussion? No. Did you ever get knocked out and black out? Oh, hell yeah. There you go.
I'll get you a bell rung.
Here we go. So I
Yeah.
just had to ask it in a different way.
Yeah.
But it is the way that being unconscious is not always obviously a good thing. And then
Right.
sometimes it's especially, and I think part of the area that we're, I find myself still a struggle for us in the field is the level of alcohol abuse that many times goes undetected, especially with people who are higher functioning, people who are older. I'm so surprised every time to see individuals above a certain age that drink wine. It starts with them communicating, well, I only drink one glass. To then me finding out that they're downing a half of a bottle an evening, and then there's some liquor going on, and then there's like before, by the time we're done with the assessment, there's a lot more that comes out sometimes, and those are people with people who are normally higher functioning, perhaps with higher level of education. You would not be expecting that.
Right.
What can you then maybe share with our listeners about alcohol and that relationship of alcohol to disorders, to movement disorders?
Well, you could easily, anytime you have any disorder, whether it's cancer or ALS or Parkinson's, that's debilitating, that affects you emotionally and limits you physically, and you desperately want to be back to normal, and you feel as if the disease, you're just getting worse and not better, that can definitely lead to depressive symptoms and, drinking that could lead to alcoholism, especially if you don't have a support system. I'm sure the statistics may show that there's fewer incidents of alcoholism when those that have a spouse than those that are
On their own.
are not married. And so, this could be a trap to fall into. I don't see it as much with Parkinson's disease. Essential tremor, even though there's no real bad outcomes from that, and they only have tremor, alcohol does help the tremor in 70% of cases, and they have a strong family history. If you have a strong family history, you're at risk. So people will use alcohol to control the tremor, and of course, with alcohol, you become more and more tolerant, and you just need more and more to get the same effect, and that's how you could become an alcoholic.
Right, which then caused them to be impaired in a different way. Now, so another area maybe that we can touch on is people want to know what other therapies they can do. So, people are always somewhat dreadful about using medications.
Right.
They know that it has a limited effect. They know that sometimes they have to use more and more of it to get the same effect. And they want other type of solutions. So what other things can they do?
Yeah, this is important because, as you mentioned with the young Parkinson's patients, the timing of medications, them having to take it sometimes several times a day, that could be difficult when you're working and busy and you're, young and active. So I try in my clinic to really promote, let's do things as naturally as we can, and let's try to keep medications to a minimum. So there's exercise in Parkinson's disease is like taking medicine. I even have a picture on my wall of a prescription bottle with a bike on it and says, take one ride daily. And so cycling, number one, cycling helps with freezing. Okay? Then there's dancing for Parkinson's disease that helps with foot coordination. There's the Mark Morris Dance Company in Brooklyn that has a Dance for PD program, and Los Angeles is going from 3 Dance for PD dance studios to probably about 6 in the past few years. They even do chair dancing, where you could just do it in your chair.
Wonderful.
There's a book I have yoga for Parkinson's. Yoga is very good. It helps with balance, stability. Walking, power walking is good. I tell my patients, if you could have a conversation while you're walking, you're not walking fast enough. I tell them to also, we make sure they don't have any cardiovascular issues, of course, and that they're safe. Don't push themselves too hard. Remain hydrated. If they're able to, lightweight resistance, using light weights helps with strength. Those patients that can't do that, I have them just fold their arms across their chest, and stand up out the chair and sit back down. Stand up out the chair and sit back down. It's a modified squat. And as long as the chair's up against the wall, and and has arm rests, it's pretty good.
And you're touching on something that we often refer to as large movements. So I come from the dance world and the dance background. So actually, for a while, I was designing that program for dementia patients for the Longevity Center at UCLA. And part of what it was is focusing on large movements, not necessarily fast, not necessarily cumbersome, but those large movements that encourage a larger range of motion, oxygen to extremities. I think that's everything that you're mentioning.
LSVT big. Lee Silverman LSVT big. The Lee Silverman training. Most of the hospitals have the big program, and that definitely concentrates on really big movements.
Yep. And going back to nutrition, just maybe we can talk about this a bit more. Part of the danger, I think, with when individuals do suffer from a progressive disease is that they tend to isolate, and they also tend to forget that they need to keep themselves a full supply of nutrients over time. So I think part of that is also the lack of nutrient, not just the exposure to toxicity. So perhaps you can expand on that issue of nutrition.
Yeah, so the Mediterranean, there's an article out, the Mediterranean diet seems to be what is being suggested for Parkinson's disease. That's also suggested for stroke and cardiovascular health. So the Mediterranean diet, any patient could Google Mediterranean diet PDF on Google, and it'll give you one. Also, when we talk about Parkinson's disease, there's something called gastroparesis, or delayed gastric emptying, where the stomach usually empties every 30 minutes, but because now it's slow moving, it will only empty maybe every 1.5 to 2 hours. Then you have a sense of fullness. You don't want to eat. You start losing weight. You have problems with absorption. If you're too constipated, things aren't moving through the gut. That's going to be a problem, not remaining hydrated. Constipation is something that most patients should not need even a medication for, even though some might, or a lot might.
But it can mostly be managed with the eating habits.
Right. There's at USC and Rancho Los Amigos, they have the Rancho Los Amigos cocktail, which is uncooked oats, applesauce, and prunes. And you could warm it up for 30 seconds in the microwave, and you could eat that 3 or 4 times a day, and it works just as good as any laxative almost. There's a medication called Linzess that basically just pulls water into the colon. That's a good medication as well. And there's a lot of over-the-counter things they could do as far as, stool softeners, things of that sort.
We have only a couple of minutes left. This has been, it's always, time passes by so fast, and there's so much always to talk about in this area. I'm always amazed.
I can talk to you all day.
Yes, we could. That's great. I could talk to you all day, and it's good for people who are listening. So we're definitely going to have you on again, Dr. Lisk. This is absolutely wonderful, and we truly appreciate it. I truly appreciate it as well. We are going to, and I know some of those questions, they always come in advance before the show, so you've covered all of them, and again, that's great. I want our listeners to know we're posting on our site now the various links to your links, your social media link, website. Dr. Lisk is also very passionate about public education. Clearly, you can see. If you have any questions or concerns further in this area, please do reach out to his website. And you can also read some great information there. And we've got it on site right now. With that in mind, again, Dr. Lisk, thank you so much for coming on the show. And doing all this great work for your population.
Well, thank you, Dr. Gaines, and I'll be more than happy to come on anytime you ask.
Sounds wonderful. Thanks so much. And for our listeners, have a wonderful, blessed week. You do know how to email me, drdgaines@gmail.com. Find us on Facebook. You know how to download also the archive. Episode will be available within about 24 hours. With that in mind, any questions, concerns, new topics that you want to be covered, old topics that you feel you still have questions, please do reach out to me and have a wonderful and blessed day.
You're listening to The Dr. D Show about neuropsychology and well-being. Get the knowledge you must have to live a powerful, positive life. The Dr. D Show. Here for you.